Thanks, Jenny, for having me and bringing a lot of patients here. So this is, I feel good when I come to these patient events, not giving the scientific lectures, but trying to tone it down so that we are talking. So this is more of an information exchange than anything else. I want to start with this slide to show the complexity of what myeloma is and what myeloma treatments are. So what Dr. Hofmeister just laid out to you is what the treatment options for the newly diagnosed patients are. So patients go into remission. They stay in remission for a very long time with the current treatments that we have. The average time patients stay in remission is in the range of more than 10 years with the 4 drug treatments, with a transplant, and going on with maintenance. So that is way beyond what we were expected or what we were doing in the past. So what happens when the patient starts to relapse here? So this is what's called a NCCN guidelines. There are patient guidelines as well. So clearly, this is very small font here, but here it shows category 1 recommendation. So category 1 recommendation means this is supported by a phase 3 randomized controlled trial. There are 16 category 1 recommendations on just this one slide. So if you're being treated by a doctor who doesn't treat myeloma, it is almost like, I don't know how many of you play chess or how many of your grandchildren play chess, but this is like, we're starting an opening move. I'm starting a Sicilian defense. And then we don't know what to do as the next step. The probabilities change drastically with every change. Take all these into consideration, all the trials. We have a myriad of options. Now you take the patient considerations, the treatment considerations, what the past treatment history comes into play. Putting all those things together to come up with the right treatment plan for the patient, it's not easy. So that's what means you got to have somebody that treats myeloma, that knows myeloma, and that is your advocate, is who you need on your team. Yet the responsibility still is with you. You are your own advocate more than anybody else. Fair enough? Now, we move to the available treatments, which are non-T-cell redirecting therapies, and there's a whole sessions that are speaking specifically on the bispecific antibodies and the CAR-Ts and the newer Revlimid and others. But what I'm going to do over the next 20 minutes is to spend more time on talking about what is cooking in the pipeline, what are the new clinical trials that we have, and how can we leverage them, how can we use them, what are they exactly targeting, because not all myeloma is the same. So you have to understand a few things. What are the genetics of your myeloma? If you don't know, write it down. Please ask your doctor so that will help you to understand what treatment options that are there specifically for you, okay? So let's start with what we have in terms of the available treatments. This class of drugs, the bortezomib, carfilzomib, ixazomib, these are called the proteasome inhibitors. These have been existing since 2005. And these work very well. These are a part of the backbones. So if you're receiving any induction therapy, you would have received one of these drugs, at least bortezomib or carfilzomib. This class of drugs are the IMiDs. So when we first started, so there is a lot of patient involvement in terms of the development of these drugs. The thalidomide is a drug that was patient-driven. So this was not a drug that came from the laboratory and somebody said, we're going to test in myeloma patients. So there was a patient that went into Dana-Farber and brought this drug and told Dr. Barlogi that this is what I need my husband to be treated with. And it worked. So all the credit goes to the patients. So being an advocate for yourself really, really helps to develop a drug. And we had a next iteration, the lenalidomide, the pomalidomide. These happened over the next 10-year periods. When you go from here to here, the next generation, the potency increases. That means it gets stronger, and the toxicity decreases. So these are very good drugs that we use on a regular basis. Now comes the next class of drugs, iberdomide and mezigdomide. These are the drugs Dr. Joseph would be talking about this afternoon, I believe. And this is a very new class of drugs that are highly, highly potent, like almost 80 times to 90 times potent than these two drugs. Now we understand how they work, so they got a new name, but these almost, they're exactly, the mechanism of action is exactly similar. Let's talk about other drugs, selinexor. works in a very different mechanism than all of these, and this is an exportin inhibitor. We have other classes of drugs, venetoclax and sonrotoclax. These drugs, this is where I was talking about. If somebody has a specific translocation 1114, they have an activity with these two drugs. None of these are approved, but we use a lot. Like we probably have treated 150 patients at Emory with these two drugs. The next class of drugs are the P300 inhibitors. I'll talk to you a little bit more about the mechanism of how this works because these may be applicable to some of you. Then comes the K36. This works specifically for patients who have translocation 414. I'll show you some data of how this works. So now that we're having those treatments specifically for that subgroup of patients, it makes more sense for you to understand what kind of a disease you have. So again, emphasizing what Dr. Hofmeister said, no, it's not the IgG, it's not the isotype that really has any prognostic significance, but what has a prognostic significance is what kind of a chromosomal abnormality that your myeloma is exhibiting that you should know from your case. Okay, how many of you know? I'm very curious. I would really love for everybody to raise this hand because this is the information that you need to know about your disease. Okay. Now, these naked antibodies, the daratumumab, isatuximab, we have used this for a long time, and these form a part and the parcel of the induction therapies to drive those disease down. Belantamab, I'll be talking a little bit more into the detail, and these really help us to, in the relapsed refractory setting, and I'll show you some data on Belantamab as well. You must have heard a lot of press about these bispecific antibodies. These work very well. These three target what I call the BCMA, the teclistamab, elranatamab, lenvaseltamab, in patients that did not have a lot of treatment options. At this point of time, when we're treating, even 3-4 years ago, these responses that you see are in the range of 30% across the board for patients that were in the trial, patients who had seen 5 prior lines of therapy. And these drugs have given us such good response rates and such good PFS benefits. And these are wonder drugs, but these are meant for late relapse or late refractory multiple myeloma at this point of time. These are all approved by what is called an accelerated mechanism. So there is a lot of phase 3 randomized controlled trials being done currently. So when they get approved, the first slide that you saw with 16 category 1 recommendations, it is going to get more complex. So more reason for you to have a myeloma-specific doctor. Okay. Now these two are the ones, the cilta-cel and ide-cel, these are the CAR-Ts. So the CAR-T therapies are the ones that you have a whole lot of a discussion with Dr. Joseph this afternoon. Again, very effective treatment, but you always have to balance the benefits and the risks. So is this really worth for me? So yes, there are several options, but what is the right option for me is the question that you need to have clarity. Your doctor needs to provide that clarity to you, okay? So just to go over, I reviewed all the drugs that we have. So we have plenty. We have plenty even to get to a cure. It's in the process, but how does the natural history of the disease go? So what Dr. Hofmeister talked about is this phase. So the goal is to get you into remission, and that remission could be obtained by using the 4 drug regimens, by using a transplant, and getting onto your maintenance. There is an option for us. So historically, patients that I'd seen 15 years ago, patients that I'd seen 10 years ago, we were putting patients on maintenance for a very long time. And we started to ask this question, maintenance has its own baggage, short-term baggage, long-term baggage. So are there patients that can come off maintenance safely? That is a burning question that we had been asking that specific question for a while, and we're leveraging some of the tools that we have to get patients off maintenance. And we start with weaning off. We start with peeling off the medications. If somebody's on more than a few drugs, start to peel them off with an ultimate goal. If you remain in that MRD negativity state for a longer period, there's an option for us to stop. So it is a work in the progress. So if you've been on maintenance MRD negative for a longer period, this is a discussion that you need to bring to your doctor, okay? So now what happens if the disease progresses? So this is where we're talking about. The early relapse setting is where I showed you that first slide. there's a myriad of options. The probabilities change based on the patient. What is the most optimal therapies? And those treatment options that you choose should not cannibalize the future treatments. So that option should be very, very specific. Myeloma is one of those diseases where the same treatment that you're getting here versus here, the benefit that you get changes drastically. So unlike other diseases. So that is why you should be very cognizant of what treatment that you're choosing at the time of a relapse. Okay. So I don't want you to think that there are no options here. I'll show you some examples. 5 years ago, when we had the patients in the refractory phase, these patients went on to receive a CAR T called cilta-cel. How many of you have read this New York Times article? Everybody should be reading this. This is for myeloma. This basically says from no hope to potential cure for a deadly blood cancer. No doctor could explain it better than this. So this basically is in June talking about this article, specifically saying a third of the patients are not only just alive without treatment, doing well. Among the 100 patients that received the CAR T in 2020, this received a standing ovation at ASCO. So things that were not possible 5 years ago are possible today. So you'll be hearing a lot about these from Dr. Joseph this afternoon. Okay. So the biggest question that always comes up is, if it works in the later lines of therapy, can it give us better benefit if you're using it early? So in the early transplant setting and the early relapse setting. So that is where this KarMMa-3 and CARTITUDE-4, both these trials have proven benefit compared to the standard of care therapies. So if you go to your doctor, if you're getting a relapse, if you're having a relapse, you're going to your doctor and they give you a regimen, like Daralandex, like any of those regimens that they're talking about, all those regimens were compared against CAR T in both these studies. And what these curves mean is, at this specific time point, how many patients did not progress versus how many patients progressed with each of these specific options. So both these trials showed that CAR T was very beneficial for these specific patients very earlier in the course. So what I'm proposing is, not every patient who is progressing early should be receiving CAR T, but it should be thought about and talked about. And if not, you should be understanding why. So again, I don't want to paint the rosiest picture here. It comes with its own baggage. So is the baggage worth it? If this is a high-risk patient progressing very early, we want the best treatment. At that time, the risk tolerance should be higher. So at the same time, when there is a patient that is relapsing very indolently over a longer period, am I willing to take that risk? I'm not. So if I'm not willing to take that risk, you should not be willing to take the risk. So that's how I look at this in a very dynamic environment. These continue to change, so that discussion has to be ongoing. Okay. Moving on to a completely new class of drugs. These are called the CELMoDs. I was talking about, everybody must have heard about Revlimid, the pomalidomide. These work exactly the same way, but what I want to show you is what we have for the future. So it's not stale, it is evolving, and what you see here is the CC220, this is called iberdomide. The cereblon binding IC50 is almost 100 times lesser at 0.6 micromolar concentrations. It's able to provide the same binding where the POM and LEN were doing at 1.2 micromolar. So think about how potent these drugs are. And these will be used in the future in the upfront settings in the coming years. And which means we're as closer to cure as possible with all these available treatments. Talk about the same thing with the ALS degradation, the Ikaros degradation. And these are the surrogates of what happens in the human body at the IL-2 secretion, as well as the PBMC killing of these myeloma cells outside the human body. These are all very, very potent compounds when compared to what we have today. Okay. When we talk about potent compounds, doesn't mean that there is increased toxicity. And this is, as we go from one generation to the next, the potency increases, the toxicity decreases. These are very safe compounds that we've used for close to 6 to 7 years. Okay. So there is one other drug that we have in the clinical trials. This is called CFT7455 or cemsidomide. And we had this as a part of the clinical trial. This is just closed, but this is a drug that has resulted in, it's similar to what works similarly to the Revlimid, the pomalidomide, but among patients that are heavily refractory who had seen 6 prior lines of therapy, you're still able to see a clinical benefit in approximately a third of the patients that received this. So very potent drug. Don't know about the drug development at this point of time, but this is something that we had as an option for patients who are progressing on CAR-T and so on. Okay, so now let's shift our gears to, I don't want this to be feeling this is a complicated slide. I'll make it very easy. So how does Revlimid work? How does pomalidomide work? So there is a cascade of events. So what we're trying to do is there are 2 markers that we use. There's 2 genes, the MYC and the IRF4. They get upregulated when myeloma is active. So the IRF4 and the MYC are basically those are helpful for the myeloma cells to live. So what Revlimid or pomalidomide do is to use these Ikaros and Ilias, so these transcription factors, to downregulate them, and that's how the myeloma cells are controlled when the T cells get activated. Okay. Now, these cancer cells are very, very smart. If a cancer drug is controlling it, they find alternate routes. So they shift the dependency to this P300. So now we don't have anything. That's why where people ask me all the time, why was it working a year ago? Why is it not working today? This is because the cancer is smart enough to evade. It is an evasion mechanism for it to shift its dependency on this P300. Now the question is, do we have a P300 inhibitor that can help us to control this, to shift this, go back to the sensitivity? And that's what was shown in these, I'll quickly jump to the trials that showed the efficacy. This is called the enobritinib. Among patients that were refractory to POM, 75% of the patients responded when they combined this drug with a P300 inhibitor. So there's biology outside the human body that is allowing us to understand what is happening, and there is a treatment that one could envision that is working. So this is meant for this subset of patients who are lenalidomide or POM refractory patients where the current treatment is not working, and purely for the understanding that how it has shifted its dependency, and now we are blocking this off. By combining both, you're able to restore that sensitivity. So this is a step in the right direction in terms of what we are expecting down the line. It's from a small molecule inhibitor development. So we won't stop there, right? So we want a better P300 inhibitor. So this OPN 6602 it has a residence time of 13 minutes, which is 8 times longer. It is 16 times more potent than the previous one. So we have clinical trials for both of these at Emory. So anybody that wants to explore into seeing what the new options that I have my own treatment options that are remaining all the time. Those won't go in anywhere, but can I take a detour to see if an option like this would exist for me that will help? You always can ask your physician. Okay. This is more of an animal data, and basically from a potential development perspective, the OPN trial is recruiting, as well as the previous trial that I talked about, the cell-centric trial is recruiting for patients that are len and POM refractory. Okay? So I talked about a specific drug called a translocation called translocation 1114. So their disease biology is quite different. So we have a basic scientist that we work with. His name is Larry Boyce, who discovered this class of proteins called the BCL2. And those class of proteins are inhibited with this specific drug called the venetoclax. I don't know if anybody heard this name. It's a lymphoma drug, but only meant for this 10 to 15% of the myeloma patients that have this translocation. Works wonders. The drug development is such that when they tried to look for in the clinical trials, they could not prove the benefit for various reasons. I would be very harsh in saying that they screwed up the drug development here. But the future drug development is with sonrotoclax. This is similar to the venetoclax, and it is currently being evaluated by a company by name BeiGene, or currently called B1. and they have found the right dose, the recommended phase 2 dosing, and they're having the expansion studies. And what they're seeing is the response rates of 70% for this class of drugs. A potential option for, again, only that subset of patients, so more reason for you to know what kind of a genetic abnormalities that you have. I don't know how many times I've emphasized, but I would keep emphasizing as we continue to go. Okay. So this is another drug specifically meant for translocation 414 patients. So this is a plot where the 14 and 4 are exchanging genetic information, so chromosome 4 and 14, so that is what's called a translocation of 414. And these express a specific gene by name NSD2. If there is NSD2 expression, this is a large database where some of you may have participated. It's called the COMPASS data by MMRF, and where they've looked at this NSD2 expression. Is it conferring any prognostic significance? And patients who have NSD2 high expression had poor PFS and poor overall survival. So can we do anything for this subset of patients? So this is a high-risk marker, and this is where the identification of what really helps in this knockout clearly shows that NSD2 inhibition with this specific compound called KTX1001 have shown the inhibition of NSD2, and as you can see on these Western blots, there is a significant downregulation of this H3K36. So there is a target, and there is a drug, and there is a clinical trial that is currently being evaluated specifically for this translocation 414 patients. So more reason for you to know, if you have this 414, there is a drug that works for this. Okay, so the trial is currently enrolling, and we do have this clinical trial at Emory as well. Belantamab, this is an antibody drug conjugate. So everybody heard about the naked antibodies. Everybody knows about daratumumab. Everybody knows about isatuximab. How this differs from both of those is it carries a payload along with it. So it is targeting BCMA, a different target than Dara-ISA, and it is carrying a payload, and this is a microtubule inhibitor. So once it attaches to the BCMA on the cell surface, it internalizes, and the chemotherapy moiety is released and starts to have a myeloma cell kill. Very effective treatment strategy. The main problem is the ocular toxicities. This was approved in the past, and because of the ocular toxicities and the dosing and the schedule that it was given, it was pulled out of the market. So for a different reason, the confirmatory trial did not pan out as well. We have always believed that this is a combination treatment. This should not be given as a single agent at a higher dose, but lower the dose, extend the frequency, and you can continue to gain the benefit when you combine with other myeloma drugs. So that's what has been panned out in the DREAM7 trial and the DREAM8 trial, where this was compared against the Belantamab with bortezomib and dex, Belantamab BVD, or daratumumab bortezomib dexamethasone, showing the benefit, significant benefit. The top curve is where any of us want to be on. And this top curve shows that patients who received the Belantamab and Velcade index, they remained on the top curve for a very long time, so for more than 3 years in this relapse setting. This is almost as good as a CAR-T benefit that one could see. Okay. Now, is it a fluke? Is it one study? The next study combined Belantamab pomalidomide dexamethasone versus Velcade and Pom and Dex. So good control arms, and what was shown here is, again, we want to be on the top curve, and the top curve is what the Belantamab curve is. It went to the FDA. Unfortunately, it was tabled as we speak because there was still a concern for these ocular toxicities. And we tell FDA, we tell everyone that you let the drug to be given, we will deal with how to give this patient. It is me having to converse with my patients to see what benefit that one can give. It should not be a regulatory decision, but we'll have to see what happens down the line once the FDA makes a decision sometime next month. Okay? So with this ocular issues with 8-week dosing, this was significantly lesser, so probably that's the dosing that we need to go with. I have a clinical trial, so we have a clinical trial at Emory that is using this combination with the Belantamab, pomalidomide, dexamethasone, only in patients that are high risk soon after the transplant. So we have accrued so far 28 patients on the trial, and we have 0 patients that progressed. Of course, this is less than a year of follow-up, but this trial is just accrued so quickly in the last year, showing that this combination could be very, very helpful for patients with high-risk disease. And this was presented at IMS last week in Toronto. And potent combinations, the key here is for you to stay in remission for as long as one can. And within the next few years, we probably will be defining cure for myeloma. So I'll end with this last concept, which is the trispecific antibodies. So we're talking about bispecific antibodies, and you heard that bispecific antibodies, which will be discussed more in detail by Dr. Shah, and these work with having a myeloma with one arm, myeloma antigen with one arm, and carrying another T cell marker with the other arm, and bringing them together to allow for that immune synapse to happen so that the myeloma cell kill happens. So the biggest challenge is 30% of the people don't respond. So the responses are in the range of around 60 to 70%. So what the trispecific is doing is carrying another arm, think about a third arm, holding up another antigen. So now what the responses that you see here is 100% responses among those patients that haven't seen the BCMA or GPRC5D, and every patient responded. So I'm so interested to see what those MRD rates look like and how long these responses continue. And could this be an option for us to move very early in the course with the aim to get the cure? So I'll stop here, and we have a great myeloma team here. We've all the clinical research teams that will help us to get the patients through these trials. We have all the research labs that work with every trial that we have. We want to understand why. If patient is not responding to bispecific antibody, understand why, so that we can come up with an alternate mechanism. And these labs really help us do that. So if somebody asks you, I make a plea, if somebody asks you for a sample, and please, if you can provide it, it will help us to understand more, because all the advances that we have as of today are all from the gifts or the benefits from the previous myeloma patients. So with that, I'll stop, and thank you for listening to me.